Good evening, everyone. Welcome to Lakshya Academy. We are all gathered here for yet another free webinar series. And today we have Dr. Prajitha ma'am with us to discuss on the topic screening of cervical cancer and staging of cervical intraepithelial. Now, before handing over, let me take the privilege of introducing ma'am to this session. Ma'am did her UG from VPSP Ayurveda College, Kottakkal, and PG in the Department of Prasudi Tantra and Stri Roga from Government Ayurveda College, Trivandrum. She started her career as a lecturer in the Department of PTSR in Kannur Government Ayurveda College, Kerala, and later served as a specialist in the medical officer at Prasudi under the Prasudi Sri Roga under NAM at District Ayurveda Hospital, Kozhikode. She has published articles in various journals and printed papers in national and international seminars and webinars. Currently, she is pursuing her PhD in Prasudi Tantra and Stri Roga at All India Institute of Ayurveda. With whole heart, we welcome you, ma'am. Now, without any further delay, let me hand over the session to you, ma'am. Over to you, ma'am.
Thank you. Thank you for that introduction. So I think we'll go to the session. Shall we start?
Yes, ma'am. Please, ma'am.
Okay. First of all, let me thank Lakshya for giving me such an opportunity. Anyway, the topic, I think it is a familiar topic. It's not something that is very different. But still, many of us may be a little unaware of certain areas regarding this specific thing. Because cervical cancer is most often dealt by any gynae doctors. So being general practitioners, being doctors of any field, we have to know certain things which is expected from us as a doctor. Because most often there are so many cases which gets undiagnosed in front of us. So we have to have a general knowledge about cervical cancer and its pre-malignant stages. Oh, so the topic is screening of cervical cancer and staging of cervical intraepithelial neoplasia. A brief about the contents. There is just, I'll tell about the small introduction, human papillomavirus, intraepithelial neoplasia and its grading and screening of CS cervix. Introduction, generally, cervical cancer, as we all know, is the fourth most common cancer among women globally, with an estimated approx 6 lakh new cases and 3,42,000 deaths in, which is the latest reports in 2020. Okay, so we can see it is approx 6 lakh new cases has been diagnosed every year. That much is the burden. And what is the situation? If we see it further, about 90% of the new cases and deaths worldwide in 2020 occurred in low and middle income countries. And so for us, for being an Indian, we have to be more concerned of this disease. It is the second most commonest in India, particularly in women. And an alarming rate we must see is 1 woman dies of cervical cancer every 8 minutes in India. We can never expect a cancer being that deadly. And what has WHO told about cervical cancer control? It has got 4 stages. It is primary prevention, as we all know, that is getting vaccinated against HPV. Secondary prevention includes the screening and treatment of precancerous lesions. Tertiary prevention means diagnosis and treatment of invasive cervical cancer. And finally, the palliative care. And which is the most important risk factor, that is 99.5% for CIN and invasive cervical carcinoma. The most important risk factors, of course, we all know, it is HPV, human papillomavirus. What is HPV? Just basics. It is a small DNA virus, as we all know. The incubation period is from 3 weeks to 8 months. It is an epitheliotropic virus. That means it particularly targets stratified squamous epithelia. So wherever we see a cancer report, most often it being cervical cancer or oral cancer, these are the areas very common with squamous epithelia and squamous cell carcinoma. So in both of this, HPV is the commonest villain we can see. Generally, the types we know HPV, we all hear that, but does every person with HPV get cancer? No. That is because there are 2 types mainly. There is low risk HPV and high risk HPV. Low risk are the one which brings out genital warts, and intermediate and high risk types brings CS cervix. The 2 human papillomavirus or HPV types which are responsible for nearly 50% of high grade lesions is 16 and 18 strands. And just a bit of things about HPV vaccination in India, because we all know, all are coming to us and asking. Many of us may have already been vaccinated with HPV, or else many patients come and ask us whether we have to go for HPV vaccination or not. All are in a doubt. So what is happening presently in India is, in Jan 2023, the Ministry of Health and Family Welfare has launched India's first indigenously developed vaccine, that is Cervavac, to prevent cervical cancer. Already there were vaccines like Gardasil, Cervarix, etc., which are not Indian origin, but this is actually been manufactured from Serum Institute, and that is Cervavac, the new name. And the target is actually 68 million girls in India will be vaccinated against HPV. And later on, HPV vaccination will become a part of the immunization program. It has two parts, like 2-dose type of vaccination is there. It is spaced at 6 months, and that is usually given in the group of 9 to 14 years age group. And there is a 3-dose regimen, that is a 0 dose between 1 to 2 months, and then 6 months in the 15 to 26 year age group. So these two types we can get vaccinated. And another important thing is, it is also important to know that no vaccine can provide complete protection against all cancer-causing HPV virus. And why screening is important? In women who undergo a routine screening, risk of having an abnormal pap smear is 35%, SIN or cervical intraepithelial neoplasia is 20%, and invasive cancer is 1%. What is cervical intraepithelial neoplasia? I'm not sure many of you might have heard this term. We have all heard CA cervix. So whenever we hear CA cervix, we also have to listen to this term, CIN, because most often in reports you may see CIN or LSIL or ASCUS. When we come across this term, we must not be thinking that what it is. These are common things. Cervical intraepithelial neoplasia is a condition which may later progress to CA cervix. What is the exact definition goes like a histopathology condition where a part or whole thickness of the cervical squamous epithelium is replaced by cells showing varying degrees of atypia. Atypia means anything which is different, which is not typical. It's known as atypia. We all know that. So there are some sort of cells. The normal squamous, cervical squamous epithelial cells has been replaced by cells which show some other different pattern. So that is known as CIN. It doesn't mean that it is cancer, but it is a condition which may most often progress to cancer. Now, what does this CIN signify? What does this emphasize? It emphasizes the continuum of CA cervix, and that alone reflects the prognostic significance. We all hear the term, we all as a patient or as a doctor or as a relative, we hear that if it could have been diagnosed 1 year before or 2 years before, this patient would have survived. So that is always the situation with cancer. But there are very rare some cancers which have a pre-malignant stage. And to say, being a faculty from Prasuti Sridog, I'm so happy to tell that CA cervix has got a pre-malignant stage, because we can identify it early and we can treat that many females. Even then, the situation is that alarming that so many people are dying of CA cervix. Why? That is because we failed to screen the condition. We failed to diagnose the condition early. So the term CIN and this topic or this class is just aiming one thing, that at least we can diagnose 1 or 2 patients with CIN 10 years before she or she later, she later turns into CA cervix. She gets diagnosed to CA cervix. At least 10 years before, we can identify the condition of CIN and we can help her to get away from cancer. Now, just a grading of CIN. This is not of, actually this is of theoretical importance. But the thing is, sometimes in reports, we can see CIN1, CIN2, CIN3, carcinoma in situ, and finally CA cervix. So just to understand why we call the grading it like that, the proportion of the thickness, we have already told it is based upon the thickness or the layer of cervical squamous epithelium, which is getting converted to atypical cells. So depending upon the proportion of thickness of epithelium showing this type of pattern, that is immaturity or undifferentiated cells, it is used for grading of CIN. As the degrees of CIN increases, the epithelium becomes less differentiated. First of all, there is CIN1 lesion. This is the least fatal. Loss of cellular differentiation is present only in the lower one-third, and normal cell maturation is in the upper two. The majority portion is normal, only the lower one-third is getting affected. CIN2 lesions, there is dysplastic cellular changes in the lower two-third. And CIN3, most of the layers are involved except for the superficial quarter of epithelium. And this is the picture. These are actually cytological pictures. This is the normal one. First picture you see, that is the normal one. We can see single layer, this crowding of the cells at the basement layer. Then there is CIN1. We can see these are normal, but here it turns a bit abnormal. CIN2 we can see this much, and CIN3 the whole layer is abnormal except for these. And the cell pattern also changes. You can see how small the nucleus is, and when it becomes CIN3, the nuclear pattern also changes. What are the commonest risk factors of CIN as well as CS cervix? We can't always say the single etiology, because single etiology, it is HPV. We all know the cause is HPV, but what are the contributing factors? What are the risk factors always which may make the person cancerous? Coming to the risk factors for CIN, seeing the gynecological factors, the commonest and the very alarming thing is early age of first sexual exposure and conception. Because we all know, both in the developing as well as in the underdeveloped countries, this is a big problem. These days, young adolescent girls get exposed to sexual, get sexual exposure at a very young age. In India, the situation is mainly because they are getting married in a very early age. Whereas in general, other countries, or generally there are situations where children start, adolescents start their sexual exposure in a younger age. So both these groups are exposed. So early age of first sexual exposure and conception, both these are a major cause which we have to think about. Next is multiparity. Multiparity, repeated deliveries. Both these causes are contributing to the injury of the cervical epithelium. The cervical epithelium, not going to the details of cervical epithelium, but still, I'm just telling about the thing that the cervical epithelium is an area where we have a dynamic point. The cells are repeatedly changing from squamous to columnar, columnar to squamous at the squamo-columnar junction and the transformation zone. So once there is already activity or dynamicity, there, whenever any type of oncogens or oncogenic factors get exposed, there is always chance of getting developed to cancer. So that is what happens with the cervical epithelium. So once these are already prone, this area is dynamic, and in younger age of sexual exposure, this is more. So once there is any chance of sexual exposure, HPV DNA, HPV virus is getting exposed to those areas, and there are always chance of micro-invasive traumas. So these traumas allows the pooling up of this HPV viruses, and that may later convert to CIN or CS cervix. Multiparity is another thing. Because of repeated childbirth, the trauma exists, which helps the HPV to lodge at the site. Multisexual partners, we all know these are STDs. So in STDs, there is always, being an STD, there is always chance of viral transmission from partner to partner. OCPs, oral contraceptive pills, are also to an extent responsible because of the hormonal changes which support the area of dynamic zone, the transformation zone, to get more active. Some other factors are also contributory, that is particularly immunodeficiency, because whenever the patient is well and good in immunity, viruses, we all know, viruses can't survive that much. As all viruses, HPV is a very common virus. Every female gets HPV infection at least once a lifetime. It's that common. Whether the strand is high risk or low risk, that matters. One thing. Second is whether the patient is immune compromised or well and good immune. If she is immune and she doesn't have any problem with her immune system, this virus sheds off on its own. But if she is immunodeficient, it can persist, it can remain there and later convert to CIN or CS cervix. Poor socioeconomic status again. Smoking. Smoking is another important thing. Even passive smoking has contributed for this CIN. Nutrient deficiency. just a picture of what the epithelium. This is the squamous epithelium. This is the columnar epithelium. This is the squamo-columnar junction, which is very much prone for the cancerous growth. We have the new squamo-columnar junction. I think all of us might have somewhere learned about this in our graduation, but still I'm just giving a glance, not going to the detail. This is the new squamo-columnar junction, and this is the old squamo-columnar junction. So in between, there is a layer called as transformation zone, and all the cancers occurs at this site. This. Directly coming to screening in CA cervix. When should we screen the patient? The American College of Obstetrician and Gynecologists has got certain recommendations for cervical cytology screening. We'll just have a glance, not going to the details. The initial screening must be started 3 years after initiation of sexual intercourse, no later than 21 years of age. Any female who is sexually active must undergo the initial screening. This mainly refers to the pap smear screening within 3 years after initiation of sexual intercourse. Now coming to the frequency, how frequently we have to do. There is a group called low risk women and another is high risk women. As we all know, the low risk woman is usually, if she is less than 30 years, she can undergo a pap smear screening annually. That's not like every 6 months, it's not necessary. She can go it annually. If she is greater than 30 years, she have to do the same thing annually until 3 annual negative smears is obtained. Cytology with HPV screening is appropriate for women greater than 30 years if negative. That is also not more frequently than every 3 years. Coming to high risk women, high risk means whether she's immunocompromised or because of any other factor, we make them high risk. They require more frequent screening. If she is HIV positive, twice in the first year after diagnosis, then annually. If she has a history of CIN 2 or 3 already, and she has underwent the treatment, it is a post-treatment follow. It must be continued annually until at least 3 consecutive negative smears is obtained. If the person has already underwent hysterectomy for the same thing or some other thing, should we go for this? Yes, in some cases. That is, there is no prior history of CIN 2 or 3 and had hysterectomy for benign condition means she can discontinue the cytological examination. If she has a history of CIN 2 or 3, she has to continue it after 3 consecutive satisfactory negative smear following the treatment before hysterectomy, then discontinue. Another discontinuation, inconclusive evidence to establish the upper age of discontinuation. If discontinued, risk factors should be assessed during annual examination. How to screen the patient? Screening techniques for cervical cancer includes the following. First and foremost, the most important one is pap smear, as you all have heard it. It is also called as conventional exfoliative smear or conventional exfoliative cervicovaginal cytology. Next is liquid-based cytology. Third one is visual inspection test, which includes visual inspection with leukocytin and visual inspection with acetic acid. Then we have the colposcopy, then the HPV DNA testing, and finally, latest one is digital cervical screening test. This is the HPV triage and test of cure protocol. I'm not going to the detail. Now let's see what is pap smear. I think most of you are familiar with this, but we'll see certain areas which we may miss. The sample collection, the timing. The sample should not be collected during menstrual period because we know the smear will be more of hemorrhagic. The women should not have had intercourse or inserted anything into the vagina at least 24 hours prior. They should avoid intravaginal medication, contraceptive or douche for 1 week before pap test. It must be avoided during obvious cervicitis or purulent discharge. If the patient is having severe discharge, sometimes what happens is we get confused. She has discharge. We feel like there is some situation that she may convert, she may develop cancer cervix or anything. You feel like that. And without examining the patient, we may send her for pap smear or we may take the smear sometimes. And we find thick discharge, cervicitis or whatever, leukorrhea or whatever. In such conditions, better not go for a smearing. Don't do, because you will get only the discharge and the sample will be inadequate. We'll have to repeat it again. So better in such conditions, treat the infection, and collect the samples only 4 to 6 weeks later. But if you find the patient is affordable or she can afford, we can go with the liquid cytology process, which I'll tell later. In that, there is no problem with the discharge. Okay. Now, postpartum pap smears should be taken at least 8 weeks after delivery. We usually don't do postpartum pap smears, but sometimes it may be necessary. And in postmenopausal women, smears may be reported as atrophy, inflammation, or lack of cells. So what we have to do, there we have to advise an estrogen cream vaginally for 2 to 3 weeks and then facilitate the cell maturation and then go for the smearing. These are the requirements, the viscous curve specula, because we have to visualize the cervix. Glass slides are necessary, fixatives, spatulas. The commonest spatula, as we all know, is Ayer's wooden spatula. This is the Ayer's spatula, the wooden one, commonly used to sample ectocervix. Endocervical brush is there. This is the endocervical brush. So this is for the ectocervix, this is for the endocervix. When we visualize the cervix, we can see the when we visualize the whole cervix, we can see the os. The thing inside the os we call it as endocervix, and outside is known as the ectocervix. Both areas we have to brush or collect, and then we'll put it on the glass slide and fix the seam. Procedure: label the glass slide prior to collection. Subject in dorsal position. Cervix is exposed with a viscous specula. And remember, we should not use any antiseptic solution to clean the vagina and cervix. But lubrication can be done. It doesn't affect the pap smear. The procedure should sample the squamous epithelia and the columnar epithelia and transformation zone. TZ should be identified and sampled adequately because TZ is the area of CIN. Air spatula is fitted to cervical os with the long end into the endocervix. Rotate the spatula through 360 degree. We have to note that sometimes what we happen is we just give a small turn and then we'll rub it into the slide. It's like we have to give a 360 degree rotation, and that too in the same direction. Once this side, it is wrong. You have to go in the same direction. The sample spread on the glass slide with a single stroke. We have to give 1 or 2 simple strokes, not like we have to rub it. Using moderate pressure to thin out the clumps of cells and mucus gets a monolayer. Avoid air drying and degeneration. Slide must be fixed quickly within 1 to 2 seconds by immersing in Copland jar containing fixative of 95% ethanol. This is another mistake we commonly commit because we'll take the smear, we'll apply it on the glass slide and we'll keep it there, and then we'll take a jar, we'll fill the fixative and then we'll put it. By that time, the smear which we have taken must have get air dried, and that will be a wastage. So we must be ready with the jar and the fixative fixative ethanol, or else we get ready-made fixative sprays. So we can keep it aside. Once the smear is ready, we can spray it and then we can send it for sampling. So this is it. This is the technique. This is actually the not the AS is this one, endocervical spatula. So with that also we have to rotate in 360 degree and then we have to rub it like this. These are some of the cytological pictures. This is the normal one. And this is ascus. I'll explain what ascus is. This is low grade lesions. This is high grade lesions. Now just some things about reporting pap test. It's not that we are going to report, but when we see the report, we have to identify it. Most commonest report is negative for intraepithelial lesion or malignancy, NILM. In some certain situations, we don't even identify if it's negative itself or is there any problem. So simply you remember NILM means it is totally normal, nothing to worry. It indicates absent neoplasia. This may include any inflammation or infection. Sometimes we see the report as negative for intraepithelial lesion or malignancy with moderate inflammation. So is that something to worry? Inflammation is very common. In anybody's cervix, we can find inflammation or minimal sort of infection. So that is very common and that is normal. We just want to see whether it is NILM or not. If NILM, nothing to worry. And second condition is epithelial cell abnormalities. And now what are the abnormalities? Being squamous cell, and internally there is columnar squamous cell in the ectocervix and columnar cell in the endocervix. Both type of cancer may occur, but commonest is squamous cell cancer. These are the term ascus, ASH, LSIL, HSIL, etc. You may see it in the pap smear reports very frequently. If you have not seen much, means you have not done that much pap smear, because that is very common. Atypical squamous cells of undetermined significance. There is some sort of atypia, but it feels like it is undetermined significance. Atypical squamous cells cannot exclude HSIL. This is more harmful. They see some atypical cells, but they can't exclude high-grade lesions. Squamous intraepithelial neoplasia or SILS. SILS, we have two, LSL and HSL. LSL means low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion. And finally, there is squamous cell carcinoma. Coming to columnar cells, similar things, negative for glandular lesions they'll give, or AGCH or AGCU it was, I think. AGCH, then there may be adenocarcinoma. Now, some of the limitations of pap smear. Only 20% collected cells transfer to slide. Inadequate fixation due to air drying results in degeneration of cells, which I've already told. Abnormal cells may be randomly distributed. What happens is we have taken the smear, we have applied it in the slide, but sometimes the whole clump may be this side and the pathologist must be seeing only this side. The cells were here, it got missed. Obscuring elements like blood, mucus, inflammatory cells, which I've already told. Manual screening of cytology slides is labor intensive and difficult. When the pathologists have to see more than 10 or 20 slides, it is really a tiresome job. They can't concentrate and they will miss the cells. Next, liquid-based thin layer cytology. Nowadays, most of the doctors prefer to do LBC. Aim is to reduce the incidence of false negative findings by optimizing the collection and preparation of cells. Cervical cells is collected using cytobrush. It has got a cytobrush. The cervical collection device is immersed into the liquid fixative and rinsed, and it is well mixed. It allows mechanical mixing and homogeneous distribution of cells in the solution. The device contains a polycarbonate container that holds a membrane with an 8 new pore size. And as the collected fluid passes through this semi-permeable barrier, the membrane detains that epithelial debris and inflammatory cells are allowed to pass. Thin cellular material spread to glass slide and fixed. The prepared slide screened manually or by automated techniques. So all the materials or the discharge, whatever it is, it gets separated. Only the good cells are there in the solution and we can fix it and see. This is the LBC kit. There will be a small jar like this with the fixative and there is a cytobrush. And same method, we'll have to collect the sample, we have to shake it or mix it well inside, and then we can open it from here and we close the jar and send for the sample. Next is visual inspection methods. These are some methods which we can identify without any instrument. We have to use the cusco speculum, we have to visualize the cervix, and then we have to apply certain solutions. And we have to watch it with our naked eyes. We can see some certain changes on the cervix. Accordingly, we can identify whether there is cancerous or not. These are some of the methods which WHO is promoting these days because these are very cheap and low setting is enough for conducting this test. And these have been even trained for ASHA workers or health workers so that anyone can screen. So being doctors, we must surely know this and we must practice it in our clinics. Visual inspection methods, there are two methods, there are two main chemicals. Visual inspection with acetic acid and visual inspection with leucocyte. Coming to acetic acid technique, we have to get a 3 to 5% acetic acid. Always remember, not direct acetic acid must be applied because once we apply it, it may cause chemical burns. We can get the glacial acetic acid bottle. To prepare 5%, it's very easy. You have to just take a 5 ml and there is 95 ml distilled water. Mix it and keep it in a jar. Keep it aside of in your clinic. You have an examination room where you use the speculum or everything like that. We do the gynec examination. We put a speculum. We'll see in well-lit room. We have to have good light coverage. Then we'll take a drop, not a drop. We'll soak a small swab with acetic acid and we'll apply it on the cervix. And after 1 minute, we'll visualize. It must be allowed to react for 1 minute. In acetic acid, we have to wait for 1 minute. And then we'll see. I'll show the pictures and we can identify the lesions. Visual inspection with glucose-iodine. After doing acetic acid, we can go with villi test, that is glucose-iodine. Here, 5% glucose-iodine. This must be also, it can be prepared or you can get it from the market. 5% glucose-iodine you have to apply over the cervix, and then we can visualize. What is the actual pathophysiology? Just to understand, why do we apply acetic acid? Acetic acid causes reversible coagulation or precipitation of cellular proteins. We know it is an acid and it reacts with the proteins and causes coagulation. Effect of acetic acid depends on amount of the cell proteins, which in turn indicate the area of increased nuclear activity. Wherever there is increased cellular activity is increased most often in cancerous cells. So when there is increased activity, there is more proteins. More proteins, it will react with more acetic acid and more coagulation. Precancerous cells, more nuclear proteins are absent and minimal glycogen. Depending on nuclear activity and nuclear protein content, the acetic acid intensity changes. This I am not going to the detail. This is actually when we are doing this, this is the reporting technique. Sometimes what we happen is we get many false negative and false positive. So better to understand, I've kept this. One or two I will explain. Via negative, we call it as via positive or via negative. Via positive, if we have to say, we have to get a strikingly dense acetovyte in columnar epithelium as relevant. Or if it is in the TZ, we have to get a distinct, well-defined, dense, opaque, dull oyster type of acetovyte lesions. These are some of the via negative conditions. There are certain conditions called as squamous metaplasia, immature squamous metaplasia. These all appear as translucent acetovyte. You can see the picture. These are certain type of acetovytes, and once we see that, we'll think it is some problematic and we'll start worrying about cancer. No, this is normal. These are the squamous metaplasia. Squamous metaplasia means these are the normal squamous cells getting developed. These are all normal. Now we'll see the low-grade lesion, how it will appear in visual inspection. See, these are low-grade lesions. Aren't there some abnormal? It has an abnormal feature, right? This is a normal cervix. We have an abnormal feature here. High-grade lesions. See, this is the normal cervix, and here see, thick. This is the high-grade lesion. Next is villi. Similarly, Schiller's test. Its another name is Schiller's test. This is based on the principle of glycogen. Wherever there is glycogen, it will stain iodine as black color or mahogany brown color. And in cancerous cells, we don't have glycogen. So that doesn't have that brown color, or it will stain some other color. Normal squamous epithelium has glycogen content and it stains mahogany brown. Abnormal epithelium, no glycogen, do not stain. Same thing in CI and invasive CA, glycogen appears thick mustard, lack glycogen, so it appears thick mustard yellow or saffron color. It's not mahogany brown color. It will be palish or mustard color. Similarly, reporting of the test is not important. These are some of the images. Like this is the normal area and these are the abnormal area. The yellowish area we see, these are the abnormal areas. These areas have some abnormality. There are more pictures I'll show you. Next, we go to the colposcopy. I think all must have heard the term colposcopy, at least. Colposcopy is actually studying of the colpus, the lower vagina and the cervix under magnification. Colposcopy is examination of epithelial surface and underlying stroma of cervix and lower genital tract under magnification and bright light illumination. What is the basic principles of colposcopy? It is based upon three morphological characteristics, that is the epithelium, the stroma, and the surface contour. When should we go for a colposcopy? Colposcopy is something which we can't do in a private clinic always, because it is a costly instrument. So it is good if we find out a nearby colposcopist. If we get for someone, whenever we screen a person with via our villi test, or we do pap smear and we find some abnormality, we can send the patient to the colposcopist, so that we can examine it well and good and find it out. When we usually go for the colposcopy, it is day 8 to 12 of the menstrual cycle is the best time to perform colposcopy. Indications. When should we do colposcopy? As I've already told, any of the positive screening tests is an indication for colposcopy, be it cytology, pap smear, via or villi. If there is a presence of LSL or HSCL in any of the reports, we have to do unexplained cervicovaginal discharge. Sometimes what happens is the patient is having continuous vaginal discharge, like 5 to 6 years, 7 years, 8 years, and the patient might have underwent all the screening, even pap smear. It is totally normal. It gives an ILM report, but still we doubt something. We have to send it directly to the colposcopist. Undiagnosed bleeding PV and also postcoital bleeding are always need to be examined. Lesions noted on the cervix, post-treatment surveillance, etc. The chemical agents used, same thing. So what we have learned in via and villi, the same thing is applied. Similarly, acetic acid is applied. Similarly, leukocidin is applied. But the thing is, we don't see with naked eyes, we see with a colposcope. We see in a magnified view, so we get better images, we get better understanding. And the benefit of colposcopy is in the same sitting, if we find a lesion, we can take the biopsy of the area and we can send it. So that is the main benefit. Colposcopic images. These are some of the colposcopic images. Squamous metaplasia, this is normal thing. This is an Nabothian cyst. Hope you all might have read Nabothian cyst and seen Nabothian cyst. Very common and it's totally normal also. It's a normal cervix. But see, we'll feel something abnormal is there. Not abnormal, it's normal. This is also normal. This type of pattern is normal. Now, what is abnormal? This is a pattern seen in inflammation. Whenever there is, we have learned somewhere, we have heard about trichomonas. Trichomonal infection gives strawberry spot appearance. Similarly, when we apply chemicals on an inflamed cervix, it gives the leopard skin appearance. This is the leopard skin appearance. Dot appearance, if we see, we can say it is an inflammation. There's nothing to worry. This also. Now comes to the lesions. LSIL, we can see an LSIL at 12 o'clock. We note these in positions of like 12 o'clock, 2 o'clock, etc. So we can see this. This is the LSL lesion, low grade lesion with acetic acid. This is the acetic acid. Colposcopy testing, we see this. And this is the same lesion after applying leucol. See, everywhere it is black color, mahogany brown color, because there is glycogen, plenty of glycogen. And this cancerous area does not have glycogen, so it is not stained. It's stained in a different color. Another LSL, you can see this like this. You can see this in the clinical practice. These are better magnified image in colposcope, but still you can see this. This one. These are high grade lesions. You can see the dense pattern. It is more thick and dense, and moreover, this doesn't disappear fast. This is the same thing with leukocidin. High grade lesion here, and this one is low grade lesion. Picture of invasive cause. There is a scoring system. It's not that important now because after doing colposcopy, we put scoring. We give scoring based upon the acetic. We have seen acetoide lesion. Based upon that, we give scoring, and we score it accordingly, and then we decide which type of lesion it is, and we go for biopsy. And if it is 0 to 4, it is CIN1, 5 to 6 CIN2, 17 CIN3, etc. Now, another testing is HPV DNA testing. Is very common these days. This test detects the presence and type of HPV, which is high risk or low risk. An HPV test can be done using the same sample from the pap smear. With the liquid cytology brush itself, we can collect the smear and we can send it for HPV DNA testing. It is by PCR method. Advantages of HPV DNA testing is it is highly sensitive. Once we get to know that she is having high risk HPV, we can screen the patient better and we can go for a treatment also in an earlier stage. It finds those who are at risk of developing neoplasia within 3 to 10 years. And the disadvantage, as we all know, is it is expensive. And this is the latest technique. These are also like we can use it in the clinics. Digital cervical screening test. Smart scope is a common one. It is a bit costly, but not that costly as a colposcope. So if any private practitioners can afford it, we can keep it in our clinic. It is also very good. We have a tab with this, and with this instrument, we can take photos and that will be displayed here, and the system itself will identify whether it is high risk or low risk. SmartScope is a transvaginal digital examination device. It facilitates close examination, magnified visualization of cervix. It is also again based on via villi principles, acetic acid and leukocidin. Steps include the same steps is included in colposcopy also. Firstly, we have to open the screen, we have to register the patient, put the details of the patient, then the screen will be getting opened. Then we have to apply the stains and then click photos, capture images. And the benefit is that there is AI enabled assessment and color coded reports. It will give like red coded, blue, green, etc. Based on that, we can say whether it is high risk or low risk. The best protection is early detection. With this ribbon I wear, I support the women everywhere in hopes that education brings early detection and research brings a cure to share. Thank you. Thank you for the patient listening.
Thank you so much, ma'am. It was really a wonderful session. And now the session is open for discussion. So I request the participants to either raise their hand or post their question in the chat box so it can be discussed. Participants with any questions are requested to either raise their hand so they can ask their questions directly, or please post their question in the chat box. Any questions from participants? Okay, ma'am, I think there are no questions. So shall I conclude, ma'am?
Sure, it's okay. Hope everyone has got everything. They are not asking any questions.
Yes, ma'am. I think they have understood the session so nicely. Thank you so much, ma'am, for that. And thank you, participants, for joining us today. Please stay connected with us on all of our social media so that you can get updates on the upcoming sessions by Lakshya Academy. And once again, thank you so much, ma'am, for first of all accepting our invitation and being here, and for such an amazing session as well. Thank you so much, ma'am, for that. And we're really looking forward to hear more from you as well. Thank you so much, ma'am.
Thank you. Real thanks to the lecture team for inviting me, giving me an opportunity to be in coordination with you people. And beforehand, I really thank my guide, Dr. Kamini Dhiman ma'am, because of whom I could do this at least. Thank you for the patient listening to all the participants. Hope it might have added a single knowledge at least for your clinical practice. And thank you one and all once again. Thank you.
Thank you, ma'am.